So it's been known for quite a while that this is a mutation that leads to cancer development. But for really over 4 decades, researchers couldn't figure out a way to target it. It was often considered something that was undruggable. But all of this changed recently. So about 4 years ago, in 2021, we had the approval of the first KRAS inhibitor. It's specifically a KRAS G12C inhibitor known as sotorasib.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Danielle Roman, Manager of Clinical Pharmacy Services at the Allegheny Health Network Cancer Institute in Pittsburgh, Pennsylvania, about the KRAS inhibitor drug class. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and then completing the evaluation we've linked in the episode notes. Welcome and thanks so much for joining us today, Danielle.
Hi, Jamie. Thanks for having me.
So to start things off, can you give us a brief overview on the history of the KRAS inhibitors in the field of oncology?
Yeah, so KRAS inhibitors are a very interesting drug class with a complicated history. But if we could just kind of step back from KRAS for a minute, and we're going to just briefly mention the larger class of RAS genes. So that stands for the rat sarcoma genes, and they've long been identified as a mutation that leads to cancer growth and progression. There are 3 different forms of the RAS gene. So KRAS is one of those. There's also NRAS and HRAS. So specifically looking at KRAS, which stands for Kirsten rat sarcoma viral oncogene. So that just means it is a gene that is known to cause cancer growth and progression. And this is a gene mutation that is commonly associated with a couple different forms of cancer. So those include non-small cell lung cancer, pancreatic cancer, and colorectal cancer. So if we look at specifically non-small cell lung cancer, this KRAS mutation is one of the most frequently detected cancer drivers or driver mutations. So it's thought that about a quarter of cases of non-small cell lung cancer have this KRAS mutation. And it's usually a specific amino acid substitution that we see in non-small cell lung cancer. So what's known as a KRAS G12C mutation. So it's been known for quite a while that this is a mutation that leads to cancer development. But for really over 4 decades, researchers couldn't figure out a way to target it. It was often considered something that was undruggable. So there was really nothing that we could do to target it for patients that were known to have this mutation. But all of this changed recently. So about 4 years ago in 2021, we had the approval of the first KRAS inhibitor. It's specifically a KRAS G12C inhibitor known as sotorasib. And then after that, a year later, we had another approval for another KRAS G12C inhibitor, adagrasib.
And I remember when that first came out and just how significant it was. As you said, we had no agents that would target this specific variant. And so for that first one to be approved was really, really quite exciting. And so I'm excited to talk about this drug class even further today. Let's talk a little bit about the mechanism of action. How do these drugs actually work?
So they are specifically working on mutations in that RAS pathway. And so we know that in that RAS pathway, when we have these mutations, what happens is these mutations are causing the pathway to be in an active state at all times. That then is triggering these downstream pathways. So a couple of those are the MAPK pathway and the PI3K pathway. And that is just leading to uncontrolled cell growth and proliferation and causing cancer. So both of these agents, sotorasib and adagrasib, have the same mechanism of action. So they bind to a pocket, very specifically on the KRAS G12C protein, and they lock it in an inactive state so that it can't cause that downstream uncontrolled signaling to happen. So they're kind of shutting down the signaling, and therefore you don't get that uncontrolled cell growth and proliferation.
Outstanding. So The mutation, the variant, basically is like the foot is on the gas pedal all the way down to the floor. And these drugs sort of put the brakes on, the emergency brake,
That's right.
if you will.
Yes.
And so as you mentioned, right now, there's only 2 FDA-approved KRAS inhibitors. What should nurses know about them, such as their indications? And then how are these agents similar or how are they different?
It's easy to think of these drugs. They have a lot of similarities, so it makes them easy to learn. Both of these drugs are small molecule tyrosine kinase inhibitors. So we mentioned mechanism-wise, they really have the same mechanism, and they have very similar indications. So the first FDA-approved indication was using these agents as monotherapy in patients that have locally advanced or metastatic non-small cell lung cancer with a KRAS G12C mutation. So very specifically in that, not any KRAS mutation, but specifically a KRAS G12C, because these drugs are binding at that G12C location. So they were both approved in that setting as monotherapy, and both approved after patients had received at least 1 line of prior systemic therapy. So using these in the second line setting or beyond, not currently using them in the first line setting. So in that way, they have similar overall response rates, similar median progression-free survival in their clinical trials. Both of these drugs are also given until disease progression or patients have unacceptable toxicity. The second indication for both of these agents is in combination with an EGFR inhibitor for patients with metastatic colorectal cancer that also have that KRAS G12C mutation and have also received a prior line of systemic treatment. So again, very similar settings. So we have the non-small cell lung cancer approval as monotherapy and the metastatic colorectal cancer approval, but in combination with an EGFR inhibitor. Where we get a little bit of difference here is in respect to this metastatic colorectal cancer approval. Sotorasib was approved in combination with our EGFR inhibitor, panitumumab, and adagrasib's approval is with the EGFR inhibitor, cetuximab. So similar drug classes here, but the approval is with slightly different agents within that drug class. Another big difference to point out, and one that is often used in clinical practice to differentiate when to use these agents, is specifically adagrasib is known to have activity in patients with metastatic non-small cell lung cancer that have active brain metastases. In the clinical trial, they included patients with active brain mets, and they found that this drug has great CNS penetration, and so may be considered the agent of choice in patients with brain mets.
That's really interesting, really important to know, since that could sometimes be the biggest challenge is, crossing that blood-brain barrier and getting activity there. So that's really important distinction. What are some of the common toxicities and the adverse events that nurses should be aware of when they're caring for patients that are on these KRAS inhibitors?
Yeah, so I'll start by saying they are often well-tolerated agents. Just kind of from looking at the differences standpoint, there does appear to be more grade 3 or higher toxicities in the adagrasib trials compared to what is seen in sotorasib trials. So potentially getting a little bit more toxicity with adagrasib compared to sotorasib. Of note, really, from a toxicity standpoint, a big takeaway here is that GI toxicities are among the most common that you'll see with both of these agents. So diarrhea and nausea and vomiting are fairly common complications that can be seen. Again, more of this generally with adagrasib compared to sotorasib. Diarrhea risk with adagrasib, about 50%. Sotorasib, somewhere around 35%. So common in both, but a little bit more with adagrasib. Same thing here with the nausea and vomiting, more frequently reported with adagrasib. NCCN guidelines considers it in that moderate to high risk, emetic risk category. Sotorasib, we can also see this, but it's categorized more in that minimal to low risk category. So potentially a little bit better tolerated with sotorasib compared to adagrasib with the GI toxicities. Another thing to note here is hepatotoxicity. So we do see increases in the liver function test with both of these agents. Again, a little bit higher risk with adagrasib compared to sotorasib. A lot of times we think about myelosuppression with our anti-cancer agents. So it's important to know here that myelosuppression is a relatively uncommon toxicity with both of these agents. So it is a potential, but an uncommon thing to see. Dose adjustments exist for GI toxicity with both of these agents, as well as that hepatotoxicity. And then in terms of something that's a little bit different here, adagrasib has a risk for QTc prolongation. So it's certainly something from a monitoring and a counseling standpoint for patients and from a drug interaction standpoint that we're going to pay attention to with adagrasib. And then a last mention here is there is a rare incidence of interstitial lung disease or pneumonitis with both of these drugs. So if that is detected in any patients, the recommendation for either of these agents is to discontinue. That's certainly something from a monitoring standpoint that we're going to be counseling and watching for.
Thank you. Again, a lot of those are side effects that we are, used to seeing, toxicities that we're used to managing. So I wonder, what are the pharmacologic strategies that we should be using to manage these toxicities with KRAS inhibitors? Are they similar to what we kind of are used to and typical, or is there anything unique that we need to be watching for?
So they are very similar to what you're used to seeing with other agents. If we look specifically at the diarrhea side effect, so it is going to be dietary recommendations that play a central role here, increasing hydration for our patients. So really all of those lifestyle modifications that we should be counseling. And then again, as you're used to, recommendations for over-the-counter loperamide as an antidiarrheal for patients to have on hand and initiate at first sign of diarrhea. So nothing really unique here, but important counseling points as these patients are starting on either one of these drugs. And then from an antiemetic standpoint, again, nothing groundbreaking here, but we know that the risk for nausea and vomiting is higher with adagrasib. So really should be considering the use of scheduled prophylaxis with antiemetics with adagrasib. Guidelines suggest that you may not need to do that upfront for all patients, but it should be a consideration. So if you have a patient that has struggled with nausea and vomiting with past regimens or is particularly concerned about this toxicity, using that primary prophylaxis upfront, I think would be very beneficial. And then in the setting of patients maybe that haven't had a lot of issues with that, certainly important to make sure they have a PRN antiemetic on hand with adagrasib, but could potentially wait and see how they do. If nausea becomes an issue for those patients, scheduling prophylaxis would be an important part of management. And then with sotorasib, the nausea risk is lower, but certainly making sure that they have a PRN antiemetic is important to do up front, and then potentially scheduling if it becomes problematic down the road. One thing that is unique from the management standpoint is with the hepatotoxicity, corticosteroids may be needed to manage that toxicity. So that isn't something that we always think about with abnormalities in liver function, but should be a consideration with both of these drugs.
Thank you for that. Yeah, I think that is important. Lots of familiar treatments and recommendations there, but the uniqueness of the potential need for managing the hepatotoxicity slightly differently, it's always good to keep that in mind. As far as administration goes, what are any considerations that nurses should keep in mind when they are caring for patients that are receiving these KRAS inhibitors?
So I think a big one is that both of these are oral agents. Thinking about this in terms of making sure that we're talking patients through safe handling precautions, what to do if they miss the dose, just all of the things to help ensure that they are not having unnecessary breaks in treatment. With sotorasib, to get the full recommended dose, it is 3 tablets, and that is a once daily administration. Adagrasib, a little bit different here. So it is, again, 3 tablets to get that full dose, but it is a BID dosing. So they would need to take 6 tablets within the day to get a full dose. So a pretty high pill burden with these agents. These are medications that can be taken with or without food, and counseling patients to swallow them whole. I think an important consideration is with sotorasib, if patients can't swallow tablets, there is information about an oral mixture that may be prepared. And so that's something you could find in the PI, you can find in Lexicomp. So a helpful thing for patients that are unable to swallow the whole tablet. Other considerations, I think one of the big ones is that there are a lot of drug interactions. So just specifically calling one out that I think is pretty impactful is sotorasib has an interaction with acid suppressing medications. So there is the recommendation to avoid PPIs and H2 antagonists in patients receiving sotorasib. They can take antacids, but you would need to space those out from their dose of sotorasib. This interaction does not appear to be the same with adagrasib. So potentially if you had a patient that could not come off of an acid suppressing medication, maybe a reason to choose one over the other. But I think that's an impactful one to keep in mind. And then there's a little bit of information. Remember that indication where we're using it in combination with an EGFR inhibitor, and specifically with sotorasib. In that situation, it's recommended that patients receive their dose of sotorasib before they get the EGFR inhibitor, panitumumab. So just kind of a unique thing here to keep in mind.
That's very interesting and a lot of complexity there. There's sometimes the assumption of, it's oral, so this will be much easier. But as you mentioned, of course, sometimes it is given in combination with an IV drug. And now that we have to consider the timing of that oral drug in relation to the IV drug, that's also another consideration for the nurses, not only to know and to ask about, but to provide that education to patients. Also, I think interesting, again, I appreciate that you brought up the notion of the pill burden and how many pills it takes to get to the dose. And that's something important to communicate because that is just one more challenge for the patients to consider and work through. And certainly taking one pill every day sometimes starts to feel kind of annoying. Think about taking 3 pills twice a day.
Yeah.
So it's just important to keep that in consideration and consider how to best counsel and support patients as they continue on this therapy. What would you recommend as some of the primary patient education points that we should be communicating to our patients, their caregivers and family when they are being prescribed these KRAS inhibitors?
So I think it's really a lot of things we just talked about and the specifics of administration, making sure that patients are understanding how many tablets, because as we said, it's quite a few that they generally need to take to get to that full dose. Another really important thing with these oral medications is talking through missed doses. Ideally, we don't have patients missing doses, but we do know it happens. So making sure that patients understand the direction and what to do if that happens. So the recommendation with sotorasib is to skip the dose if it's been more than 6 hours from the time that it was due. And that changes to 4 hours with adagrasib. So skipping it if it's been more than 4 hours with that agent. Another thing, again, is the once daily administration with sotorasib, the twice daily administration with adagrasib. Ideally, that is the twice daily would be separated about 12 hours apart. Another important thing is the monitoring parameters. So we do know hepatotoxicity is associated with both of these drugs. So patients do need to be counseled about the monitoring of LFTs that's recommended throughout therapy, but is more frequent monitoring in those first 3 months that they're on the medication. So just making sure that that is something that gets scheduled and that patients have that in mind. QTC prolongation, we mentioned with adagrasib. So monitoring a baseline EKG is important with that drug. And then particularly for patients, if they're starting on any medications that could prolong QTC, or if they're known to have issues at baseline, we may want to do repeat monitoring of EKG throughout treatment. Another important point here is ILD monitoring with both of these drugs. So we said it's a rare complication, but counseling patients to report any new cough, shortness of breath, fever, things that could indicate a potential, can be nonspecific, particularly a patient with lung cancer, but we want to keep ILD on our radar as a potential complication. And then I think the last thing to add here is really that there are a lot of drug interactions that we've talked through already, and just reporting any new medications or any herbal supplements is really important so that there can be a point that we're making sure to check, monitor for any interactions that may need to be dealt with.
As I'm listening to just such a thorough and great response, it just strikes me, certainly not unique just to these KRAS inhibitors, but really all oral anti-cancer drugs, of just how important it is to have dedicated, intentional management of our patients who are receiving these oral drugs, even if it is in combination with an IV medication, but especially for those that are only on maybe a single agent or just an oral-based therapy, of just how many variables there are to juggle, how much information we need to not only give to the patient, but kind of follow up on and sort of monitor for the patient, whether it's those routine lab draws, just checking in on them since they may not be seeing us every week like they are maybe with an IV drug. And so I think these drugs in particular really just highlight the importance of having someone or a team of someone's helping these patients manage this therapy as they continue on it. So in sort of follow up to that, how do you see pharmacists and oncology nurses collaborating to help manage these adverse events, toxicities, provide the patient education, and really just serve as that trusted source of information and that point of contact when patients have questions or concerns?
Yeah, I think you made some great points. It needs to be a collaborative endeavor to make sure these patients are monitored appropriately. We are putting a lot of responsibility on the patients with all of this. So again, completely, administered generally in the home setting, a lot of monitoring, a lot of adverse effect, need for reporting and management. So there's a lot happening here, and it takes a team to accomplish this and to do it right. And I firmly believe that this is often a collaborative effort between our pharmacy and oncology nursing teams to make this happen. So working together to ensure outreach to patients, I think that patients are often more successful with these medications, with early identification of toxicities when we're doing scheduled outreach. So this can look different, particularly for patients that they may need more outreach initially. And then once they are really stable on the medications, that could potentially be backed off. But I think having a plan of working together to ensure that happens is really important. Making sure that they're having that appropriate lab monitoring done to monitor for the hepatotoxicity is important with both of these agents. And identifying those drug interactions. So working together as a team, leaning on our pharmacy colleagues to help to figure out what to do in these situations where we do identify a drug interaction. So I think there are a lot of important points of working together as a group to make sure these patients are successful.
And I'm sure, as most of our listeners know, how oral oncolytics are managed in their specific site or organization can look very different. And sometimes it is sort of primarily overseen by pharmacy. Sometimes it's a nurse, like an oral navigator or oral oncolytic navigator that helps manage these patients. And sometimes it's a combination of both of those. And I think what you've pointed out is that both of our specialties have a vast amount of information and knowledge to share and contribute, all for the betterment of the patient. And so finding those opportunities to lean on each other, use the skills and the expertise from each of our specialties is definitely going to set us up for the best success for the patient. So I agree completely with all of your thoughts. So Danielle, what do you think the future looks like for these agents and their role in the landscape of cancer care?
Well, I'm excited. I think, as you mentioned previously, there was a lot of excitement at the time that these drugs were approved, just because there was a thought that maybe we would never get there with KRAS inhibitors. So I think a lot of excitement at having them. And now I think it's just really figuring out how to best use these drugs. So there's a lot of ongoing clinical trials looking at using these in combination with other agents. So potentially using them in combination with immunotherapy in the non-small cell lung cancer setting, using these with other targeted agents. So I think that there is the potential that we're going to see more of these trials result and hopefully have a better understanding of how to best use them. And I think another thing here is exploring other KRAS mutations. So we know that G12C is a particularly common KRAS mutation, but there are others, and exploring agents that potentially would target these other KRAS mutation variants.
Definitely exciting things on the horizon just to see how much more these agents can do. And as you mentioned, other targets that we can find similar to this. Well, Danielle, thank you so much for all the information you shared, your expertise. I think this is a really exciting drug class to cover, and hopefully we'll have more agents to include along with these two, and certainly hopefully soon, because I think they are really going to be powerful. As we reach the end of our episode, we always like to run through a series of quick fire questions that help to summarize some of the talking points that we discussed today. So to start that off, how do you think healthcare professionals should sort of evaluate their hidden or implicit bias when they are caring for a patient on a KRAS inhibitor?
Yeah, so I think a big point here is realizing that these are oral agents. And I think sometimes a bias, thinking about whether a patient might be able to be compliant with an oral, might be able to afford agents that can be cost prohibitive here. So I think that is something we want to keep these agents in mind for a patient. We certainly need to consider patient's ability to be compliant, patient's ability to be able to afford the medication, but there are a lot of options here to assist patients with these things.
What are some common misconceptions about KRAS inhibitors?
A big thing is that the two agents that we have on the market right now are very specifically for that G12C mutation. And we might see others picked up on next generation sequencing. So particularly G12V and G12D are ones that we can commonly see in pancreatic and colorectal cancers. But the agents that we currently have on the market are only targeting that G12C mutation.
What's something about this topic that's not often discussed, but you wish people knew more about?
A couple things off the top of my head is oral agents in general can be very cost prohibitive. So knowing that there are assistance programs and grants that can be helpful to patients and being able to afford these medications. And I think the medical staff, or pharmacy and nursing staff, can really work together to support this process and identifying these options for patients. And then going back to just having those regular check-ins with patients can be really helpful to ensure toxicities are managed. We don't want patients stopping these agents prematurely for diarrhea or nausea that could be controlled with supportive care strategies. So being aggressive in these check-ins and making sure that patients are able to continue on the medications is really important.
What additional training or education do you think oncology nurses need to stay current on this topic?
Yeah, so I think listening to things like this, listening to podcasts on your commutes can be really helpful. That is something that I have regularly done in my practice to keep up with this rapidly evolving field. Another thing that I frequently am using in my practice is the ONS HOPA ACCC patient education resources. So if you're not familiar with this, there's a website, oralchemoedsheets.com. And I have found those to be incredibly helpful resources in supporting patient education. There's just so many agents now and so many different toxicity profiles that I really think this resource is an incredible one to be able to hand to patients really succinct and great management strategies that are listed there.
Outstanding. That certainly is a wonderful partnership with NCODA and HOPA and ACCC for us to be able to create those sheets. In addition to that, are there any other resources that you would recommend, whether it's for patients or maybe even other providers who want to learn more?
Yeah, so I think manufacturer websites have some great resources, both from the healthcare professional and the patient side of things. So I have used those on occasion. The ONS Targeted Therapy book is another helpful resource. And then I'm always going back to LexiComp. That's my kind of go-to to quickly go to admin instructions as a check before I go in and talk to patients.
Danielle, thank you again for your time today and sharing all of your knowledge and helping us just have one more drug class under our belts so that we can feel confident when we're talking with and educating our patients. Do you have any final comments to share with our listeners today?
Yeah, I would just say there's certainly something to keep in mind for patients. Generally, a very well-tolerated drug class. And as long as we're keeping those supportive care strategies in mind and, appropriately using dose reductions, hopefully this is something that your patients can really benefit from. Thank you for having me.
Thank you. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.